Welcome to this 10th A-Care Level Up webinar entitled Advancing Treatment Options in Hereditary Angioedema, New Frontiers in Oral On-Demand Therapy. My name's Connie Katelaris and I work in Sydney, Australia. Joining me today, we have our panel of speakers and experts. Shown on this slide. We have Professor Hilary Longhurst, Dr. Marcin Stubiecki, and Professor Anna Valerieva. The learning objectives for this webinar are for you to understand the ongoing need for oral on-demand treatments in HAE despite the availability of effective prophylactic options, including insights into patient preferences and treatment burdens that are associated with injectable therapies. We hope that you'll also gain up-to-date knowledge of the clinical development and trial data from the emerging oral therapies such as sebetralstat and deucrictibant. The agenda for tonight is that we will have Hilary present on the need for oral on-demand therapies addressing gaps despite effective prophylaxis. That will be followed by Marcin discussing the burden of injectable on-demand treatments, understanding patient preferences and challenges, and then Anna will inform us about the emerging oral therapies with a review of the clinical trials with sebetralstat and deucrictibant. It'll be then time for us to discuss and answer your questions. There are many of us on this particular webinar and we come from 52 countries. This webinar has CME accreditation, and in order for you to obtain that, we would appreciate you completing the feedback survey at the end of the webinar, and I'll show this QR code again, and then you will receive your CME points. Please leave your comments and questions in the Q box or in the chat on the Zoom window at the bottom of your screen. Just a heads up for the next webinar, which will be the 11th A-Care Level Up, and that will be held on November the 11th, where we'll identify and address the unmet needs in HAE, a global physician perspective. We would like you to register, and again, I'll show this QR code at the end of the webinar. Scan it and you can register already for the November webinar. Please stay connected with us on social media and websites. And you can subscribe to our newsletter to be informed about our upcoming activities and dates. That's it from me, and without further delay, it's my pleasure now to welcome our first speaker, Hilary, who will address the need for oral on-demand therapy addressing gaps despite effective prophylaxis. Thank you very much, Hilary.
Okay, I hope that everyone can hear me and can see that. Thank you very much for inviting me. It's obviously a very exciting and important topic because, of course, we've just got our first oral on-demand therapy and we're soon to have a second one. These are my disclosures, and I'm actually going to leap right in because we don't need to be told in this webinar that HAE, due to C1 inhibitor deficiency, results in intermittent, unpredictable swelling of any part of the body. And clearly, whether it's your hand that's swollen up, your face, intra-abdominal, there's disfigurement or disability, and it's hugely detrimental to one's quality of life, one's ability to work, enjoy family life, contribute to society, and of course, if there's laryngeal swelling, there's a significant risk of asphyxiation with a really a concerning lifetime mortality for people who don't have access to acute treatment to treat those swellings. So our aim as doctors, we of course don't see our patients when they're swollen or rolling around in agony or unable to work, because they generally don't come if they feel an attack coming on. They don't come and see us. But nevertheless, it's our duty to understand that vicious circle of physical, psychological, and economic detriment. And we know that we can deal with this. By giving effective treatment, we can prevent this happening. I think we do have some education for our peers and also for our funders. So this is a quote that I heard several years ago when I went to a new hospital. There were several HAE patients. They were having a lot of trouble with their HAE and with living their lives. And in fact, many more people came forward once the first people had effective treatment and they could see that there was benefit in coming to the doctor. So when we see that first patient in our clinic, we have 20 minutes, half an hour to actually convince them that we've actually got something to offer them. And for me, that is giving them something that they can treat that attack when they feel it coming on. So we do, of course, have good treatments for acute attacks. So this is the contact pathway. So factor 12 activates kallikrein, activates bradykinin, and you can see that there are these feedback loops. So once there's a trigger, which is usually imperceptible, then this pathway, if there's insufficient C1 inhibitor to control activation of factor 12 and plasma kallikrein, this pathway can proceed very quickly, and there can be huge local excess bradykinin, which leads to huge local excess plasma extravasation and angioedema. We can, of course, give C1 inhibitor, which has to be given intravenously, and that's very effective in terminating the attack. We can also give icatibant, which is given subcutaneously, which blocks the bradykinin B2 receptor, and again, is very effective. The beauty of icatibant when it came out almost 15 years ago now was that it was something that each patient could hold at home and could administer to them themselves. We also now have sebetralstat, which is an oral plasma kallikrein inhibitor, which we hope will be the next, address that barrier of not wanting to inject oneself or carry injectables with you. And coming soon, hopefully, we've got deucrictibant, which is an oral bradykinin B2 receptor blocker. So what do the guidelines say about HA? Well, they talk about acute attacks. All attacks should be treated, almost 100% agreement. Any attack affecting the airway really should be treated because these are the ones that can be fatal and the initial symptoms can be very non-specific. And everyone agrees that attacks should be treated as early as possible. The reason being is the earlier you treat, the less severe the attack, the shorter the attack, and the less overall disability and disruption to one's life. Nevertheless, when we look at the overall goal of treatment, which is to achieve total control of the disease and normalise patients' lives, if you're having attacks and having to treat them, it's going to be difficult to achieve that. So we also recommend that patients are evaluated for long-term prophylaxis, taking into account patient preference and disease factors and the disruption that HA is causing to the patient's life. And we have a lot of very good prophylactic medications, either already licensed, so C1 inhibitor, ideally given subcutaneously to return that C1 inhibitor level as close as possible, ideally into the normal range functionally, will almost completely stop attacks. We have lanadelumab, an injectable monoclonal antibody against plasma kallikrein. We now have garadacimab, factor 12 monoclonal, donidalorsen, an RNA silencing for pre-kallikrein. And soon to come, we have a long-acting plasma kallikrein monoclonal, hopefully allowing 3 to 6 monthly injections, and deucrictibant in a long-acting formulation, which will block the B2 receptor. And we even have Lonvo-Z, which is a gene editing treatment. And all of these are proving very, very effective at controlling attacks in trials. And in the case of lanadelumab and sebetralstat, which I realise I've left off, in real life. So why do we need acute treatment? So I think there were several reasons. The first reason is really patient choice. And I look to our experience of chronic spontaneous urticaria, which I think many of us as immunologists, allergists will have had a lot of experience with. So chronic spontaneous urticaria is a histamine or mast cell mediated urticaria, sometimes with angioedema, which can be, although not likely to be fatal, can cause great detriment to patients' quality of life. And it's relatively easily treated with high-dose antihistamines, but no one likes to take high-dose antihistamines. And I'm sure that all of us who do clinics where we look after people with chronic spontaneous urticaria finds that it's very difficult to persuade people to take regular tablets and regular treatment if the attacks are intermittent or if things are controlled. And this is actually one of the main challenges that I face with the CSU. So I think that we would find that even with the ideal prophylactic treatment, there are going to be patients who really prefer to just treat attacks when they come along, particularly those patients who don't have frequent attacks. And of course, if those attacks are easy to treat, then so much the better, and so many more patients may choose this. The second barrier to prophylaxis is availability. And availability is problematic. So if you look to the left, you'll see this algorithm. This is issued by NHS England, and this is the algorithm for allowing people access to modern long-term prophylactic treatments. We can use the old-fashioned ones whenever we see fit. So if you're over 12, it's and you have 2 attacks or more per month, you can get sebetralstat. But to get, which is very effective for most people, but sometimes it has tolerability issues, although these are usually overcome after a while, and may not work completely for everyone. So in order to move on to other modern treatments, you need to have 2 attacks or more per week, despite sebetralstat or androgens or tranexamic acid. And then there's all these other things that need to be considered. So it's really very difficult to get intravenous C1 inhibitor and lanadelumab, and the NHS England has not yet pronounced on more modern treatments like garadacimab. And you can see here, I had a little look, and apologies if I've made any mistakes, but it seems to me that if you're lucky enough to live in Germany or Japan and you have hereditary angioedema, you can get the prophylaxis that you need. That's great. If you live in the USA or Canada, then you can probably get it if you have insurance, and I know that there are compassionate access programs. In France, you get it if you're a difficult case, so probably not too bad a situation. In Poland, I think we estimate there are a couple of thousand patients with HA. 50 lucky patients can have lanadelumab. Australia, you need to suffer for 6 months and you need to have treated at least 2 attacks per month prior to getting lanadelumab. And if you want subcutaneous C1 inhibitor, it's 2 attacks per week. In New Zealand, these treatments are not available. We have 3 patients out of 100 patients affected who have been able to assess lanadelumab after a lot of pressure and paperwork from their physicians. And then so perhaps this is the most important reason. We've been blown over by the effectiveness of the new long-term prophylactic treatments, and many of our patients feel they've got a new life, they're attack-free, they're feeling a new confidence. But in fact, when you look at the data, no treatment is actually 100%. And this is a bit of work that I did with some colleagues last year. And I hadn't really emotionally understood, what I was going to see. So we looked at 58 publications in the last 25 years. There's a lot of evidence about HAE treatment, prophylactic treatment. So 46 studies, 13 of which were randomized control trials, generally very good quality. There were open label trials, and there was quite a lot of observational data, including prospective observational data. And again, all pretty high quality. And what it shows is we know this data, but I think we don't understand it when we see patients doing so well. But actually attack-free rates are not that high. About 50% of people are completely attack-free, depending on exactly what you're using with modern treatments. But almost everyone has the occasional attack. And I certainly have had patients who've gone on to investigational prophylactic treatments, have felt wonderful, have felt very confident that they're not going to have attacks, and have gone on holiday without their acute treatment. This is not current advice, it's certainly not my advice, but sometimes patients do it, and actually I've now strengthened my advice because a couple of times people have had maybe exceptional stressors when on holiday and have actually had attacks, which of course when you don't have a treatment are extremely distressing and inconvenient, and potentially very dangerous and potentially very expensive, and certainly messes up one's holiday. You can see that these attacks are actually not trivial, because at least half of them are treated with C1 inhibitor or Katelaris, which what was available at the time of this meta-analysis. And for people who were not taking prophylaxis, it was even higher. And we do have the impression that when people are on long-term prophylaxis, attacks are less severe. But it doesn't mean that severe attacks are not possible. And in fact, when we look at the data, if you look at lanadelumab, subcutaneous C1 inhibitor, you can see that the attack severity is really not that much different when the attack comes through. Strangely, IV C1 inhibitor, the attack severity was significantly less. With lanadelumab, you can see for the doses that we use now, 300 milligrams 4 times a week, the attack severity is less, but nevertheless, 14% of people, or 7% on the 7 to 14% of people did have severe attacks. And again, with garadacimab, you can see that it looks as if there may have been a reduction in attack severity, but nevertheless, severe attacks still did occur. And even more importantly, attacks can occur at all regions. And some of the studies appear to show a greater percentage reduction in peripheral attacks compared to abdominal or laryngeal. And I think there may be various reasons for this. One benign reason could be that people mistake intra-abdominal or laryngeal non-angioedema symptoms and treat earlier. But I think it's likely that these attacks do occur. And of course, patients are much more likely to treat these symptoms early, even if they're on effective prophylaxis, because of course the consequence of those symptoms progressing are so much more severe. And in fact, in all the studies, we find that 2 to 7% of all attacks are laryngeal, and this is irrespective of what prophylaxis people are taking, whether it's modern prophylaxis like C1 inhibitor, or old-fashioned or lanadelumab, or old-fashioned prophylaxis such as androgens. And then just to use an example, lanadelumab, although absolutely there was a reduction in all attacks, including a reduction in the number of laryngeal attacks, the proportion of laryngeal attacks, which was very low at run-in, only 1%, was higher during the observation period. And with sebetralstat in the studies here, you can see that laryngeal attacks did seem to occur maybe not quite as frequently as with placebo, but maybe a slightly higher proportion than a slightly less good reduction than we saw with the peripheral attacks. So the guidelines have responded to this, and we continue to strongly recommend that all patients have sufficient medication to treat at least 2 attacks, and also that they have that medication with them at all times, which is a problem if you're going to have to carry parenteral treatment and inject it in the community. And just to remind ourselves about the reason for this, this paper, which was a seminal paper, came out in 2012, and it was actually presented at the Hungarian C1 inhibitor deficiency workshop. And there was great focus at the time about this 30% mortality in undiagnosed people. So this was a cohort of several hundred people who attended the specialist centre in Mainz, and patients were looked after with the state-of-the-art treatment at the time. They could all go to their local hospital and they could get intravenous C1 inhibitor 24 hours a day whenever they wanted. And what was very clear to me, and actually very not missed by many of our patient reps, was there was also a 10% mortality in people who were diagnosed with C1 inhibitor deficiency, but had to go to the hospital to get their treatment. And we now, I think we don't have the evidence, but I'm now convinced that the solution to this is you give your patient their acute treatment to hold at home, and you educate them about the natural history of that laryngeal attack so that they treat early. And in case you think that we've sorted out this problem, it's happening. It's happening, in a country near you. So this is a study from Brazil, which was published, I think, this year or last year, and looked at 197 HAE patients from 46 families. And this study actually did virtual histories and virtual autopsies of these patients, and 254 of their relatives who had symptoms very suggestive of hereditary angioedema. 65 of these relatives had died, and the virtual autopsy judged that over half of them had died of HAE. And this was just in one generation, just so that that memories were still relatively fresh. In fact, 74% of people who had a family history of HAE had actually lost family members, likely due to HAE. And of the people who died, the vast majority, nearly 90%, were not diagnosed. People died despite taking danazol, so obviously they were diagnosed, and nearly half of those who died pre-hospital. And they lost about 20 years of life. This is actually in contrast to the 31 years of life lost noted by Bork and his group, but probably related to the lower life expectancy in Brazil where this study took place. And it became very clear that the problems were the same. People were having relatively mild symptoms, so it was throat pain and feeling something in the throat, very non-specific. It wasn't, in the early stages, shortness of breath or anything too alarming. Sometimes there was a voice change, and it took people an average of 4 hours to seek medical help and an average of 8 hours to death. But like the Bork data, some people had very rapid progression and died within an hour of noticing the onset of symptoms. I think in Bork's series, someone died within 15 minutes of noticing symptoms. Other people, it was much longer. And people died at any age. So there were children who died, and there were old people who died. And people died after one episode of laryngeal edema or after many. In the Brazil case, the diagnosis was often not made even after death. So there were diagnoses of allergy, tonsillitis and all that stuff. And no one who died in this study had effective treatment. 3 people had fresh frozen plasma. And then there's another trial that I found where there's a similar problem. This is in China, where we we might be inclined to think, because of early cohort studies, that laryngeal edema was not quite so common. But actually in this study, looking in China, again, relatively recently, this is 103 patients with C1 inhibitor deficiency and 233 family members with suggestive symptoms. 30 people died of laryngeal edema, and they died in youth and early middle age. So in conclusion, many of our patients will not want to take HA prophylaxis, will not need to, either because they choose not to or because they can't get medication. HA attacks will occur whether on or off prophylaxis, and these will include laryngeal life-threatening attacks, not to mention all the other attacks which prevent people living their lives to the full. So all patients should carry treatment for acute attacks at all times and should be empowered to use that treatment. Thank you very much.
Thank you, Hilary. I'll just remind everyone, if there's questions for Hilary, please place them in the Q&A box. And now it's my pleasure to welcome Marcin from the University Hospital in Krakow, Poland, and he'll address the burden of injectable on-demand therapies, understanding patient preferences. Thank you, Marcin.
Hello, everybody. Thank you, Connie, for introduction. I'm clinician and allergologist, internal medicine doctor, working with HAE patient from more than 20 years. And I start with sharing the presentation. So the topic is burden of injectable on-demand treatments and understanding patient preferences and challenges. And this is my conflict of interest. And the milestones we observed during last year in on-demand management of HAE is the first one is access to the specific on-demand treatment. And those treatments, it was mentioned by Hilary, is plasma-derived C1 inhibitor, recombinant C1 inhibitor, ecallantide, which is available in the United States, not in our region of Europe, deucrictibant, and sebetralstat, which was registered on, I think, July 2025. The second milestone is the understanding of need of self-administration of treatment, and we'll go through next slides to understand why this problem is so important. And something from the history, I think that Hilary made a great input to this problem to work on international home therapy consensus in 2010. The history of home infusion and self-injection in HA began in the 90s, and I think it was inspired by German group and Canadian doctors working with hemophilia home therapy. And then the same rules were transferred to HAE patient, and it was all collected in 2010. And I think in Budapest in 2009, there was a discussion about the home therapy among the patient with HAE. And of course, the similarities were between the patient with hemophilia and HAE, and it was possible to treat HAE patients the same way. So this is self or partner administered C1 inhibitor infusion. They were safe, effective, and improved quality of life. What are the barriers of hospital-based treatment? Of course, this is sometimes the distance from the hospital or emergency room, making up the decision to go to the hospital, and the time you spend at hospital, sometimes it lasts half of a day. Delays to competing emergency in emergency rooms, delays may be fatal in laryngeal edema. So despite this is our recommendation, all laryngeal edema should be treated as early as it's possible, but it should be also observed in emergency room because of the outcome. Reluctance of healthcare staff to treat early. I think this is everywhere the same problem, that there is some kind of segregation of the patient, and sometimes our patient, they wait in the queue for getting just the injection. So many attack remains untreated. It increased disability, absenteeism, and socioeconomic burden. What are the patient's burden and responsibilities in home therapy? Patients with trained partner must decide when to treat an attack. We know that it should be treated as early as possible, perform infusion or injection safety, ensure proper disposal of equipment, keep treatment records, dates, lot numbers, and be sure that there is always treatment at home for the next attack. Partial transfer of medical responsibility from physician to patient or a partner, psychological and organizational load on patient and families. There should be training and ongoing demands, training programs, multiple session supervised by specialists. Patients should treat at least one attack under medical supervision. Regular refreshing training required every 12 months, because some of the patients, they have not so frequent attack, and they are not treated all attack, so they should be trained, and this knowledge should be reminded to them. Ongoing need for emergency backup and specialist support. Physical and emotional burden of injections. This is the problem in case of vein punctures, intravenous therapies. There's a need of venous access and technical skills. Training often takes multiple sessions from 5 to 10, depends on the reports. There are some barriers like fear of needles, self-injection, anxiety, safety concern, pain. Burden extends beyond the attacks because patients are afraid. Do they manage next attack? Will they be possible to get into the vein? Patients' preferences and self-administration, of course, they prefer to do it at home if there is only such a possibility, because it reduces time from the beginning of the attack to treatment, from hours to minutes, improves quality of life, lowers missed days at work, school, reduces hospital use. Subcutaneous deucrictibant, easier, convenient, higher satisfaction, because there is no need to get into the veins. Some patients still prefer healthcare provider administration, especially for severe attacks. And of course, we have some clinical data from clinical studies, and I think this is the study done by Aberer. It was just after the registration of icatibant, and the efficacy of treatment was high. The symptom relief was about 1 hour, the beginning of symptom relief, and almost complete resolution was 8 hours. We can compare it to the clinical study with icatibant. There was a need for patient to come to the hospital, and the time frame was 6 hours. So we treated in fast studies. I think it was fast 2 and fast 3 study. We treat patients after this time frame of 6 hours. The vast majority of patients successfully self-injected treatment after training. Safe profile, most adverse events were mild and localized, the same we observed in hospital. Injection site reaction, swelling, pain. No new safety concerns emerged compared to previous physical administered studies. Patient satisfaction, patients reported high confidence and satisfaction with self-administration. They valued faster treatment access and this kind of independence in treatment. And this is a prospective study which was done in Italy for patients who never used plasma derived. So Berinert, they never used Berinert at home. So before study, 100% of attacks require hospitalization. During the study, it was only few percent, 8%. So this is the huge change. The median time delay of injection was 2 hours from the onset of infusion. So the treatment was quite fast after the beginning of the attack, and the resolution was observed in 6 hours. Mostly mild infusion-related reactions, swelling, pain, sometimes the side effect, and it's sorry, this window is decreased from 37% to 13 over the time. There was the global satisfaction with treatment increased significantly over 6 months. Stress related to injection decreased from 50 to 27, but it's stressful giving this injection. So we should know about it, that this is not the same situation as with subcutaneous treatment. Patient preferred home therapy over hospital therapy, and this was about 80% of patients who preferred this kind of treatment. And this is Mauro Cancian. This was the poster on Quarter A conference in San Diego last year. It was collected online, self-reported survey in the group of 31 of adolescent about the last attack, how it was treated, and it was 68 of moderate, 29 severe attacks. 26% require emergency department or hospital care for the last attack. Mean delay to treatment was about 5 hours. Only 10% was treated in 1 hour frame from the onset of the symptoms. Treatment-related anxiety, 45% were extremely anxious. This on the scale from 0 to 10 was between 7 and 10. Higher anxiety was associated with longer treatment delays. And in this group of patients, most common use was plasma-derived C1 inhibitor, and it was 65%. So we can say this treatment, it's stressful. We know it's effective, but this is still problem to make the injection for patient with HAE. So when we go back to the recommendation from the last guidelines, there is recommendation number 23. We recommend that all patients have an action plan. So despite the possibility of treatment in the hospital or at home, there should be a plan, and the patient should work according to the plan. depends on the situation, depends on the localization of the attack. Recommendation 25, we recommend that patients are treated by specialists with specific expertise in managing HAE. So we can advise our patient how to treat the attack. We can learn the procedures, and we can repeat it. I know that also the patient advocacy is very important, and there is huge input in patients training for example, in Poland with patient association. Recommend that patients who are provided with on-demand treatment license for self-administration should be thought to self-administered. So this is incorporated into all guidelines starting from 2010. And the last, it's some kind of conclusion. I ask patients to speak about the HAE and about the treatment. I hope it will work.
Hi, my name's Rachel and I'm a HAE patient. I was first experiencing symptoms of HAE around about the age of 2. At this time, my family had no knowledge or experience of HAE, so I went undiagnosed and endured severe symptoms for many years. I suffered from frequent attacks, probably 1 or 2 every fortnight, which most often affected my hands and my feet, but also my stomach, made me vomit and severely sick. These attacks were not only really painful, but actually also quite disruptive and caused me to miss a huge amount of time off of school and impacted my daily life. Thankfully, I didn't experience any symptoms of throat swellings at that time before my diagnosis, although I have had a couple since, and they can be extremely frightening and of course life-threatening. When I was finally diagnosed at the age of 15, it led to testing my immediate family members, and we found out that my father, my grandmother and my great-grandmother, who had by that point sadly passed away, as well as my brother and sister, also had HAE. Despite these difficulties, understanding the condition has allowed my family and me to better manage our attacks and to support one another. As a child living with HAE before my diagnosis, I often felt really different from my friends. I didn't understand why I was experiencing these swellings and severe pain and vomiting so regularly, and no doctor I saw could explain these symptoms either. I just wanted to feel well and be like all of my friends. When I finally got a diagnosis, it was a huge relief. I realised there was a reason why this was happening to me, and importantly, there were treatments I could have that would relieve these symptoms and I would feel normal again. At that point, any treatment that was offered to me to relieve these symptoms was welcomed. I didn't care what they were, I just wanted to feel normal. I wanted to be free from pain and the swelling and the isolation. Having a diagnosis gave me hope, it gave me a sense of control, and it gave me a chance to feel less different. From my experience of living with HAE, I can't stress enough how important it is to be prepared. Even if you've been diagnosed but you aren't currently experiencing any attacks, HAE is so unpredictable. Swelling can come on suddenly, and when it affects the throat or the airway, it can quickly become life-threatening. Having a personalised plan in place has been a lifesaver for me. Just knowing how to recognise the early signs of an attack and having access to emergency treatment, and understanding exactly when to seek urgent medical care at the hospital. This can make all the difference. Learning about the different HAE medications, including on-demand and preventatives, has also helped me feel more in control. HAE patients should always have a choice about their treatment because not one treatment suits all. So being aware and ready just isn't about safety, it gives peace of mind and helps you live life more confidently, even with the uncertainty that living with HAE brings.
Well, thank you very much.
Thank you very much, Marcin. And now I welcome Anna, who hails from the Medical University of Sofia in Bulgaria. And Anna will address emerging therapies with a review of clinical trials with sebetralstat and deucrictibant. Thank you, Anna.
Thank you, Connie. Thank you, all your colleagues. So thank you, everyone. Thank you for having me. And it is my great pleasure and true excitement to actually speak on this topic about the exciting emerging oral therapies for acute HE that are now emerging. So we are going to review the clinical trials with sebetralstat and deucrictibant. These are my disclosures. So we heard very well from Hilary and also from Martin, why do we need new acute therapies for HE? Indeed, anxiety related to treatment of HE attacks is great, and this is causing not allowing our patients to adhere to guidelines and treat as early as possible. And we very well know that it is of great importance to catch exactly this window of opportunity for our patients to be able actually to stop the progression of the attack and actually diminish the number of hours spent with angioedema and the detrimental burden that this is causing to our patients. So I'm excited today that we're speaking about emerging new therapies for HE and especially for treatment of acute attacks. So under the spotlight, we have deucrictibant and sebetralstat, and one of them has actually received its FDA and EMA approval, and this is our first stop today. So sebetralstat is a potent oral kallikrein inhibitor, which is available as an oral tablet. And as we know, this is an upstream regulator of the entire kallikrein kinin system. So we have decrease of the cleavage of high molecular weight kininogen and also control of the autoactivation of the factor 12A positive feedback loop, thus diminishing the HE attack occurrence and progression. So by terms of regulatory approval, the drug has already received its approval from EMA and from FDA. And just last week, on the 19th of September, it received the marketing authorization in Europe. The drug will be available for treatment of acute HE attacks for adults and adolescents above the age of 12, and available as a 300 milligram film-coated tablet. Please be aware that there is a difference in the approval of the agent. So in Europe, it would be available as a 300 milligram dose for treatment of the attack, and if needed, the second dose would be permitted in about 3 hours after the initial treatment, while the FDA has registered the 600 milligram dose, which means 2 tablets. So please refer always to your local approval because it might differ. So let's look here in the phase 3 confident trial. This is the pivotal on-demand trial with sebetralstat. It recruited patients above the age of 12, and they needed to present with at least 2 attacks in the last 3 months. The actual number of patients who treated attacks were 110, and they treated altogether 264 attacks. So the design of the trial was to be a 3-way crossover, and patients needed to treat either 300 milligram dose, 600 or placebo. And at that time, with the randomized trial, there should be an approval by an investigator that the attack is allowed for treatment with the IP. So you can see here the median time to treatment was also very impressive, 41 minutes upon recognition of initial symptoms. If we look in the milestones that were achieved throughout this study, you see that beginning of symptom relief assessed by the patient global impression of change for being a little better into consecutive time points is seen to be much faster in both doses that were tested. So 300 or 600 milligram had the initial beginning of symptom relief within 1.6 to 1.8 hours. And this was also pronounced for the patients who presented with reduction in attack severity compared to placebo. And again, you can see this is quite different in the 2 doses that were treated either with the 300 or the 600 milligram dose. During the phase 3 study, laryngeal attacks were very few, so analysis about the localization here cannot be withdrawn, but we're going to look further in the other study. Well, with regards to complete attack resolution, this might be the most important for our patients question: when does the attack stop? So this is patient global impression of severity evaluated as none by the participant, and as you can see, it is much faster with the patients receiving both doses. An actual number of patients who achieved this complete attack resolution within 24 hours are, you can see, 43 to nearly 50% of the patients treated with the 600 milligram dose. With regards to safety, as you can see, the drug was well tolerated with a safety profile which was comparable to placebo. There were 3 serious adverse events, but none of them was related to study drug, and none of them occurred within 3 days after exposure to sebetralstat. The most common side effect that was reported with sebetralstat treatment was headache and nausea you can see it, and there were no changes in physical examination, ECG, and lab parameters, including liver function tests. Let's move forward to the sebetralstat open label extension. This is the Confident S trial, which is an ongoing trial with a 2-year open label extension, and patients are allowed to have treatment without having the need to qualify the attacks, or they're allowed to self-administer 600 milligrams of sebetralstat as early as possible upon recognition of symptoms. And the total number in this data analysis that was recently announced is 48 participants treating 640 attacks. Most of them treated most of the attacks throughout the entire period treated with sebetralstat. So even here, looking into this data, it allows us to discuss that this is the first study to present such adherence to the guidelines with early treatment upon recognition of symptoms, because as you see, median time from attack onset to initiation of the treatment was 9 minutes with all attacks that were treated with sebetralstat. And for the adolescents, this number is even much more fascinating. So they treat it as early as 3 minutes upon recognition of their symptoms. And also for laryngeal attacks, speaking about the possibility of having laryngeal attacks, is that this is of vital importance for the stopping of the progression and the decreasing the risk for having a fatal accident. Something also of great importance here is that it was a very high treatment rate throughout the entire study. You see 97% of the attacks that occurred through this 2-year open label extension were treated, and 84% of them were treated with sebetralstat. If we look further into the key milestones of improvement after initiation of treatment with sebetralstat, so the first primary endpoint was onset of symptom relief. You see 1.6 hours, reduction in severity in 6.6 hours, and complete attack resolution with a median of 21 hours. And as you can see, most of the attacks actually achieved these milestones with the first or only dose of sebetralstat that was used. Conventional on-demand therapy as rescue was used in just a few patients, in 36 out of 640 attacks, which is also great and encouraging. With concerns to safety, as you see, sebetralstat demonstrated favorable safety profile without clinical significant lab abnormalities. There were no new safety signals observed throughout this open label extension study, and there was no dysphagia reported even for laryngeal or abdominal attacks. There were 3 serious adverse events, but none was related to treatment, and only 1 severe related to treatment adverse event, which was diarrhea in 1 patient. So we're excited also to have the possibility to see the further results from the CONFIDENT-S trial. It incorporated in its design a way to investigate the agent for short-term prophylaxis, and I hope that we will see these results in the upcoming 2026. So let's move forward to the other agent, which is deucrictibant. It's an oral B2 receptor antagonist with during its late stage of development. This is the phase 3 ongoing, currently stopped for recruitment, and that analysis is pending and expected by the end of this year. So hopefully we will hear more about this agent as well. The mechanism of action, as discussed, it's a potent bradykinin B2 receptor antagonist. The name comes from the heavy hydrogen or deuterium atom, which was incorporated in its structure. You can see it here, and it's slowing down the rate of the metabolism of the drug, thus improving its pharmacokinetic properties. So in the initial studies, therapeutic exposure was achieved very fast, allowing for its development for on-demand therapy. So this RAPID-1 phase 2 study was a randomized study to compare 3 doses of deucrictibant, 10, 20, or 30 milligrams, and they were compared to placebo. And as you can see, 62 patients treated 100 and nearly 150 attacks, and there is a clear difference of the end of progression compared to placebo. So the patients experienced end of progression within 25 minutes after treatment with all doses that were treated. With concerns to safety, the RAPID-1 study demonstrated a well-tolerated profile at all doses that were tested, with no treatment-related severe or serious adverse events and no changes in lab parameters, ECG, or vital signs. This has been further demonstrated in the RAPID-2. This is the open-label extension study, which is recruiting patients for both the phase 2 and now in the phase 3 study. And as you can see, again, the safety profile remains unchanged, well-tolerated at all doses. Here is the data from 337 attacks without changes in lab parameters, ECG, and vital signs. With concerns to the design of this open-label extension, as mentioned, it is a pooled analysis. It is a study that is gathering patients from the phase 2 study, but also from the phase 3 study. We're looking now into the Part A double-blind phase pooled analysis for the 3 doses with deucrictibant. So if we speak about the major milestones, the onset of symptom relief assessed by the patient global impression of change is within 1.1 hour. And then we have a reduction in attack severity in 2.6 hours and complete attack resolution within 11.5 hours. The same and comparable results are discussed also for the upper airways angioedema compared to other attack locations. Another interesting story here is that the single dose of deucrictibant actually led to achieving complete attack resolution within 24 hours in most of the patients with a single dose of deucrictibant. And as you will see, nearly 99% of the attacks did not require standard rescue injectable therapy, which is also great achievement throughout this study. The durability of response is another interesting analysis, which was performed as a post-hoc analysis in the RAPID-2 program. You can see that this achievement is defined as maintenance of serial milestones of symptom relief and resolution after a single exposure to deucrictibant within 24 hours after the administration, and this is seen in very high percentage, 95, 98 to 100% of the attacks that were treated in both the phase 2 study and also the open label extension. So to further raise announcement, we know that deucrictibant is also curious for being the first therapy under investigation for both prophylaxis and also on-demand treatment, and it might turn out to be the first say maintenance and reliever therapy for treatment of bradykinin-mediated angioedema. And with this, I would just highlight on some key takeaways. We know that this revolution in HAE management by terms of acute treatment of angioedema is giving more autonomy and convenience for our patients, which are crucial for the improvement of better care and of course guideline adherence. These new therapies are reducing the barriers to angioedema treatment and is building bridges for better care of HAE. And if you allow me on some game of words here, we know that standard of care is considered having a life jacket when we are on a boat or having an airbag in our cars. And I believe this swift and on-demand control is to follow, and our patients would be given this opportunity to have a safety on call with as easy as a golden key in their pocket to be promptly taking them to a safe place whenever needed. Thank you for your attention.
Thank you very much, Anna. Now, we're nearly out of time, but we do have one question in the Q&A. And Marcin, I'll address this to you. How do you proceed if patients' and physicians' opinion regarding the treatment strategy differ significantly? How far should we as physicians go in pursuing our views over the patients'?
Okay, I think you should hear me. I'm reading this question. Yes, of course, in the countries where we have available more than one treatment, so this is we can discuss with patient, and in most cases we believe the patient's experience. And they choose the treatment for the attack. I think that in severe attacks they choose the possibility of plasma-derived C1 inhibitor. Of course, depends on the situation, but we don't. We believe our patients. So our suggestion is to use the treatment as fast as it's possible. So whether it's possible to start with the icatibant, then to use the second dose of the icatibant because it's much easier. But in many cases we observe like in those from the Mauro poster that many patients they used C1 inhibitor and they in many cases they are going to hospital. So it's not so easy this situation, and we cannot pursue the treatment to the patients. We leave it to them.
Thank you very much. So with that, it remains for me to thank our speakers for wonderful presentations and to remind you that you can claim your CME points by scanning this QR code, completing the feedback form, and you'll receive your CME points. Remind you also about the next level up, which will be November the 11th. I'm sure you'll have more notice about this. And again, you can scan the QR code so that you can register already for that. But I'm sure there'll be emails about that in due course. Stay connected on social media and with the websites. And you can stay connected on social media and websites, and you can look at the newsletter by scanning this code as well. We must thank our sponsors who have made this webinar possible. And once again, I'd like to thank all our speakers for their very valuable contribution and wish you a very good day from all of us. Thank you.